Let's spend a little bit of time talking about radiation protection for the patient. And here's some overview things that we'll be looking at. It looks like part of my slide got cut off, but we're going to go right down this list of communication, how important that is, immobilization, shielding, and that will largely relate to radiography. We'll talk about exposure factors, repeat images, unnecessary procedures, which will relate to all of us. Thinking about the amounts of radiation, the ethics, so we'll have a short introduction to ethics of patient radiation exposure. And we'll talk about pregnant patients, and I'm not really sure what it's cut off at the end, so we have a mystery section at the end. Okay, but the part on pregnant patients will relate to us all. Okay, so communication. Anytime we are exposing a patient to radiation, we should be very, very mindful of the way that we're communicating with them, because that person's probably fairly stressed out already, right? So they may not be listening to much of what you're saying, and in fact, talking to them about it may not be necessarily the best way to even communicate what you need to tell them. As we've learned, we've done a lot of reading in this class, a lot of writing in this class. Reading and written information related to radiation safety may be the best way for a patient to really get through this stuff, right? So not just talking verbally through, like, for example, BERT, but actually offering the patient, maybe if it's a diagnostic exam that's been scheduled and they're going to come in for the scheduled exam, it may be helpful for them to receive like a flyer saying this is the amount of radiation you could expect to receive from this exam, this is what that is in a background equivalent dose. Because then they can talk to family members about it and really figure out what is this something that they want to do. But the number one way that we can, I think, personally, from my experience working in this field, relieve patient tension is focus on AIDIT, as generic and goofy as that sounds. AIDIT really does help you develop a rapport and trust with your patients. Use BERT, and specifically talk about how there are both benefits and risks to the procedure. Right? There are benefits of this procedure. We can figure out what's going on with you today. There's some risks. They are related to radiation exposure. This is the amount of radiation that you'll be receiving. This is about what that is in background equivalent radiation time. So it's like 2 weeks of radiation or 6 months or whatever, what have you. We always practice ALARA, and then TRACE. I put that in here because these are like those posters and things in the department. They're just yet another way we can communicate to the patient that there are risks related to radiation exposure, and they should be aware of that. At the same time, very often, repeat radiation exposures, this is especially true in medical radiography and CT, those repeat exposures can be linked back to maybe some poor communication. So if the patient moves voluntarily or whatever reason that we don't get the image that we need, that may have been resulted from poor communication. I would say that our communication to the whole, and I think our textbook talks about this, should be patient-centered. So we should find ways that we can communicate with our patient that's going to be meaningful to them and focuses on their care, right? Offers them choices as much as possible. So we will be immobilizing patients. This is probably true for all of us in here. And this is to prevent any kind of motion, if at all possible. Involuntary motion would be things like the movement of gas inside of the digestive organs, or like chills and tremors, things like that. Or if a patient is, in withdrawal, active withdrawal, they may be shaking. Voluntary movement would be things like breathing, things related to age, anxiety or mental discomfort, physical discomfort, those kinds of things we'll call voluntary. Did you have a question? No? Okay. So things that we can do as x-ray techs and this is also true for nuke med and for radiation therapy, is if it's all possible, shorten the length of time of any kind of radiation exposure, right? So shorten the length of time that we're receiving information from the gamma camera, the length of time that we're receiving information from our x-ray equipment, the length of time that we're doing a therapeutic exposure. Any way that we can shorten a radiation exposure will reduce the risk of patient movement causing problems for us. So for us in x-ray, the main way we do that is we'll bump up the MA and decrease the time. Shielding. When at all possible, we should be shielding the lenses of the eyes, the breast, thyroid, and the family jewels. Okay? Kind of goes without saying. I think we've beaten shielding to death in this. Here's the types of shielding the book mentions. The top three are largely related to patient, and then the clear lead shields are what we stand behind as therapists and as imaging technologists. As a rule of thumb, gonadal shielding should be done for X-ray patients when the field is within 5 centimeters of the beam. And for female patients, we can shield the ovaries, and this is a way to locate the ovaries that our textbook mentions, is that they'll be about 2.5 centimeters medial to the as-is. Okay? X-ray techs, you probably can anticipate some kind of question related to this on your registry, right? But for me personally, I've never worked at a facility that required shielding of female patients. I don't know if anyone's seeing that in the clinical sites, but it's not something that I personally have seen protocols requiring. Shielding for kids, interestingly enough, if the tissue is more than 2 centimeters from the primary beam, shielding is probably not very effective for pediatric patients. The primary form of radiation exposure they will get is related to internal scatter, and so the best thing that we can do with pediatric imaging is to collimate. Okay? Here are some of the exposure factors that may help us reduce patient radiation exposure. So bearing in mind the area that we're exposing, the mass per unit volume of the tissue that we're exposing, understanding how the effective atomic number plays a part in radiation exposure, so that as that goes up, we're going to see a photoelectric effect increase as well, and that is a form of ionizing radiation. We can disregard this right here. So forget about anything you've ever read about film screen combinations. That's out. Like, we don't even have to worry about that stuff anymore. The big ones for us right now, in terms of what they're asking us questions about and what we should be thinking about as we work in the clinical site, is the SID. And with the advent of digital, we are starting to ask about increasing SID. I just read an article over the weekend that was talking about doing abdomen x-rays at, like, I think it was... we typically do those at 70 inches. It was asking, what if we did those at 120 inches, right? Would that decrease patient exposure? And interestingly enough, it would, quite a bit. So we're starting to ask those kinds of questions. What would happen if we increase SID even more? So that's kind of the new cutting edge right now for X-ray. Filtration employed, and so we'll drill down into that. And then the type of X-ray generator. Preferably, we want a pretty high-frequency generator. This is a big takeaway for X-ray techs, but it is not as much a factor for nuke med and therapy. If we increase that KVP by 15% and with a corresponding decrease in mass, as a rule of thumb, we're going to decrease patients' radiation exposure. So digital allows us to do this because it is not as dependent on, as film was, on KVP being tied to contrast. It can get contrast out of these images in a way that's much different from the way film worked. Largely, it's a linear relationship instead of a curve. So anytime as X-ray techs we're doing repeat imaging, or as radiation therapists, whenever we're doing radiation repeat images, there probably needs to be some kind of repeat analysis program in place. Now, I don't know how many of you guys work in facilities where they delete images that they have repeated, or do they keep their images? There's some of them, yeah, some of our facilities do that. They can still go in through the DICOM and see even those deleted images, right? But in the absence of some kind of program that's analyzing that, we'll probably continue to see incorrect exposures and repeat images. And so doing analysis related to that, you can get quite a bit of information. And this, I should stress, is not just a patient exposure concern. This is also a financial concern for departments, because if we're having to repeat repeatedly exposed patients, guess what? We're also going to go through our tube that much quicker, because every exposure that we make with our x-ray tube is going to reduce the tube life. Unnecessary procedures. I was just talking to Abby Kurtz about this today. There's a lot of unnecessary procedures that we do in diagnostic imaging. I think the number one is typically CT that gets cited the most in the literature. When maybe just the patient needed an ultrasound or something like that, or maybe they could have gotten away with just an x-ray. Those can be difficult decisions to make, but you are part of that decision-making process, and so if you feel like this procedure may not be correct, whether it's a nuke med study or x-ray or whatever, it is appropriate to talk to the radiologist, talk to the reading radiologist. They will then communicate with the ordering physician to figure out if this is the most appropriate examination for the patient. I would say of all the slides on this, this is probably one of the most important ones for us to be thinking about in terms of moving this field forward and not just being considered button pushers. The ways that this relates to all of us, and it's something that our textbook gets into at some depth, but the ways to specify an amount of radiation received by a patient is either the entrance skin exposure, the bone marrow dose, and the gonadal dose. And these are all calculated by our health physicists based on the kind of exposure the patient was exposed to. So we can do ESEs, bone marrow doses, and gonadal doses for any kind of radiation exposure, internal or external. And these are the number one way that we will quantify the patient's radiation exposure. So if there's ever a question about a misadministration or what kind of radiation is the patient exposed to from X examination, this is the way that they'll quantify that. So I would memorize these three things. They're fairly important. I don't expect you to know how to calculate this stuff. Just know that it is important. This is what the health physicists are trying to calculate. Let's have just kind of a brief taste of some of the ethical considerations that come out of this, and these are the things that our chapter kind of points out. Fluoroscopy-guided positioning. Who here has actually witnessed with your own eyes a tech using a fluoroscope to position a patient? Okay. Our book goes into some depth on that. I don't know, it's worth reading. That's a really bad idea. It's outside of our scope of practice, right? I know, someone should tell the techs at Baptist. It's been an ongoing issue for our facility, right, that we have these techs doing this. But I want to just point out that according to the ASRT, it's outside of our scope of practice. The book also mentions that in terms of the ARRT, it raises a number of questions as well. But it's something that continues to go on. When we actually do the math and make the determination, is this reducing patient dose or not? It is not reducing patient dose to do fluoroscopy-guided imaging. I would say the number one thing that we've identified in the literature and also here as we've worked on different things in our department is there's a need for continuing education and training. And I can't say quite enough about that. So the big professional societies, the ARRT, these licensing and certifying bodies have identified this as the primary way that we're going to try to rectify that and change this culture. A quality control program. As far as I know, Baptist operates in the absence of a quality control program. Or if they have one, it is used in a very limited way in that information is never given back to technologists as a way to improve their imaging. Nuclear medicine, have y'all noticed anything different in your facilities? Are there quality control programs where they're saying, hey, this image was appropriate, this was not appropriate?
No, I mean, if something's not set up right, you're going to have a radiologist call you and say redo it.
Okay, good. So the radiologists are in communication with y'all. Yeah. And because y'all are maybe doing like 6 to 10 exams a day or something like that? More than that? Really? Okay, great. Well, it is helpful to have that communication, and that's the one area I think that X-rays changed the most since I've been in the field. Initially, whenever I was done with an exam, we still had this nice little hangover from film where I would go in and tell, even though we were using a digital system, I'd go in and tell the radiologist, hey, I'm done with this chest X-ray. right? And then they would tell me, oh, that looks like crap, or that looks pretty good, good job, right? That was really, really helpful, and that essentially is a quality control program, right? Right now, as far as I can tell, Baptist is no longer operating with something like that. For radiation therapy folks, y'all have a whole lot of quality checks in place and a whole lot of interlocks that y'all have to clear, and so we'll talk more about that when we get to personnel stuff. Standardizing technique charts, when at all possible, is a great, great tool for us, and so once you have established, hey, this is the imaging equipment that we're going to work with, asking all the technologists, whether it's portably or within the department, to use like a standardized technique chart. This is also really helpful to those health physicists if they have to calculate an adverse exposure or an inappropriate exposure. They can go back and say, okay, well, we used a standard technique for this patient's exposure. Okay, here's what the entrance skin exposure would be. And then, like we've already talked about, a repeat analysis program. These are all the ethical considerations that our chapter brings up. Are there any other ethical stuff that y'all have noticed in your course of work? I'd be especially interested in hearing from the. So for the pregnant patients, whenever they're going to undergo any kind of examination, it is up to us, the technologists, to figure out when the last known menstrual period was, and if necessary, suggest that the patient should have a pregnancy test. So this comes from the NCRP, and they said that ideally elective abdominal examination for a woman of childbearing age should be done within the first few days after onset of menses, right? So anytime we're doing a CT to rule out kidney stones, things like that, that's like an emergent care thing where we're not sure if this is appendicitis or kidney stones or any of a number of other things, we kind of throw this rule out because this is just talking about elective abdominal examination. I have yet to find a scientific body that's really come forward and made a strong opinion about the kind of work that we do in diagnostic imaging where we're imaging people in a non-elective way, more than we are ever imaging people electively. So I say all that to say that what we've had to do is say that very often patients should be getting these kinds of procedures even if they are pregnant. For the most part, diagnostic x-ray procedures result in a fetal exposure of less than 0.01 gray, and so the risk of abnormality is incredibly small. Okay? So if you receive, and the way that this would happen in your clinical site is patient shows up, doesn't know they're pregnant, but they also suspect like appendicitis, or they suspect a car accident has occurred and they're trying to rule out fracture. We still need to get a clear HCG back. We need to know whether or not this patient is pregnant, right? And then if that patient is pregnant, we're going to shield them appropriately and still do the examination, right? And we're going to document the heck out of it, and we're going to specifically document what kind of KVP was used, what kind of mass was used, what kind of exposure was made to the patient. So if need be, they can do those calculations, right? But chances are they'll look at the protocol that was done and say it was fine. So here are the kinds of things that we need to calculate that gonadal dose. The X-ray unit that was actually used, the number of projections taken, and the technical exposure factors. Here's what a form would look like to be completed. We would give this form then to the physicist. Different facilities have different forms like this, but we would give this form to the health physicist and they would come back with an estimated dose, a calculation. There is a link between radiation exposure for pediatric patients and risk of fatal cancer, solid cancer in adulthood. And the risk of radiation-induced leukemia is also about 2 times that of what we would expect in adults. So pediatric patients are at an increased risk for problems related to radiation exposure. So that's one of the reasons, for example, St. Jude has thrown down all this money to look into things like ultrasound contrast or the proton beam therapy type stuff, because they're trying to find ways to decrease pediatric radiation dose. They also are trying to come up with like a total package. What would be this patient's dose for treatment for this lymphoma, just for example. So they want a notion of what is our quality standard for this treatment. What do we expect total package, everything from diagnosing CT scan to follow-up CT scans to PET imaging or the therapies themselves. What is the total package we would expect this patient to expose, so they can start to do the risk related to that, which is actually a really good way to be thinking about it. So in response to that, we've had campaigns like Image Wisely and Image Gently, and a need to child size KVP and MA. One of the things I'm reading about right now is that it may be appropriate to start to child size our contrast exposure as well, or just really basing contrast, any kind of contrast, on the patient's weight. Because, for example, CT and X-ray contrast increases patient dose. So that's a field that needs more literature around it, but it's something I anticipate changing in the upcoming years. And I went back and I just was curious. This is the final slide. This is a program that's out there that you could have on your cellular phone that could be used to explain to patients what you're doing, like especially pediatric patients. I had to do quite a bit of pediatric CT scanning, and we really need the patient to hold still. And so a lot of times I gave patients my cell phone quite a bit for them to play with or watch a video while I'm doing the CT scan. People probably think I'm crazy. But anything that we can do to educate these pediatric patients to make sure they hold still is going to be that much better. So this one's called duckydeck.com.